Hi guys, back for another POCUs video. Hope you'll enjoy this. This is just a didactic video on what you really want to look at in terms of right heart function. It's a presentation that Heather Hurdle and I used to do at CIS when CIS was still happening, pre-COVID. So what we're going to be looking at are the goals of the presentation, as looking at what is our recommended POCUs views to look at the RV. And then how to assess RV size, RV shape and function. And for the more advanced POCUs users, we'll look a little bit at RV and IVC pressures. So what are our recommended views for RV? Well, as you will see, we do see the RV in almost all of our POCUs views, but some of them show us more than the others. So what do we get from each of these views? So in our subcostal view here, the RV is very well seen because it is our closest, it is the closest cardiac structure. So we can really see RV function, and we can look at pericardial effusion here as well, very clearly seen. If you get a very good subcostal view, sometimes you can see comparative sizes, but in terms of comparative sizing, your apical 4 is probably your best bet, and we'll look at that a little bit more, what that means. Looking at your septal interaction between RV and LV, your parasternal short axis is probably your best bet, and you're going to look at whether this LV is nice and round, or whether you have this flattening, which is the D-shaped septum. And then in our parasternal long, we do see the RV, but a little bit hard to assess properly unless it's really badly dilated. So how do we look at RV size? Well, we can do measurements, or we can just eyeball it. If you're going to just eyeball it, we're looking to a third to half of the LV. The measurement that I would recommend that you potentially do if you are going to do a measurement is this one here, which should be about less than 42 millimeters, and you do that in diastole. So a little bit of caution in terms of RV assessment. You do want to just really think about the fact that the RV is like a semi-lunar shape, and so depending on where you cut through on your 4-chamber view, you might get different appearance of size of the RV. So if you're cutting at number 1 here, you're going to get this size RV, and then if you're cutting along that line, this still looks like a really good apical 4, right? But the RV size is different, smaller. And then if you cut through here, still looks like a very good apical 4, but the RV is still smaller. So once you start getting good at this, what you're going to do is get your apical view, and then you're going to rotate your probe and to see if the RV gets smaller or bigger. If it gets smaller, you're going to rotate in the opposite direction until you get the RV to maximum size, and then it'll get smaller again. And then you pick the biggest size to look at whether RV is normal size or not. This is a bit of a complicated slide, not too much that you need to know about this, other than that we underestimate size and overestimate function when we look at echo versus mitral with our MRI, cardiac MRI, compared to cardiac MRI. So if your heart looks big and it looks like it's not working well, then it is big and it's not working well. Probably bigger and working less than you think. Okay. Looking at size and shape again here. So the RV needs to be this kind of shape. Sort of a triangular shape. When you see an RV that starts looking like this is an RV that's probably getting dilated, and not a good position, not a good place for the RV to be. The other place that we look at the septum, in this previous view would be in the apical 4 that you would want to see that kind of shape. Now, in your parasternal short axis view, we were talking earlier about the D-shaped septum. And as you can see here, the septum is getting flattened compared to that. You know, whether this is happening in diastole or systole or holocycle, gives you an indication of whether it's volume overload, pressure overload, or both. Okay. So now we're looking at RV function. So what kind of function, how do we assess function? So at CIS, they teach two things. They teach the fractional area change and the TAPSE. I do not recommend the fractional area change as being very helpful. You can do a visual, but not like a visual estimate, but I wouldn't suggest that you do it the way they describe it. The TAPSE, however, can be incredibly helpful to help your eye. And what the TAPSE is an M mode that goes through the base. So it's a tricuspid annular plane systolic excursion. So once you've done the M mode, it'll give you a trace like this, which is the movement of all of these structures over time. Okay, so you're going to look at this point. This is this point, and you can track it then over time. So diastole, systole, and you're going to look, okay, here it is in diastole, there it is in systole. Okay, you're going to look what the difference is in movement. This is 24 millimeters here. Now normal would be 16 millimeters. Less than that is considered an abnormal TAPSE. And the suggestion from the American Society of Echocardiography would be that this is a test that we should be performing. It is simple, it is reproducible, it is prognostic, and it is very much recommended. Now, a fractional area change basically means that you, just like you do the ejection fraction on a ventricle, you look at volume, or in this case surface area, during diastole and systole, and calculate what your fractional area changes, which is kind of similar to calculating what a stroke volume is. Stroke volume is just a volume versus an area. And as you can see, so this would be normal, and then this would be mildly reduced, and this would be severely reduced. The one thing I do want you to just kind of eyeball is this shape again of this RV. Remember how we said those two sails with the more the triangular shape is normal, and when it becomes that big billowing sail, that's an abnormal shape. And I wouldn't want you to really trace out this fractional area change, but you can eyeball that to that looks pretty normal, and that to that does not look normal. And that's really all we need to do in ventricular ultrasound. It's not really super recommended by the ASE. It's not that simple, not that reproducible. It is prognostic, and I do recommend it, but with the caveat that it has to be an experienced provider. Some of the hemodynamic assessments that you will see is the RA pressure and the RVSP. So the RA pressure, we will be looking at the IVC. So you're going to measure the IVC diameter. And then you're going to look, so this would be the diameter, and then you're going to look at the amount of collapse, and then you're going to guesstimate or estimate what your IVC pressure is based on that. So basically, if your IVC is very small and is collapsing, your CVP is low. If it's very big and not collapsing, then it's high, and then you have an intermediate curve. Okay? So not super helpful in ventilated patients, but in spontaneously breathing patients, if you get a good picture, this can be helpful to assess volume status. Now, to estimate PA pressure, so this, if you're going to learn any of the continuous wave Doppler parameters, I would suggest that RVSP is a useful one. And what we do is we do continuous wave Doppler through the tricuspid valve and look at the tricuspid reverse, and then there's a calculation that gets done in the machine that gives us the difference between RV and RA, which is your right ventricular systolic pressure. And then you have to add so it's the difference between the RV and the RA. So you have to add RA pressure, which is that calculated pressure based on IVC, or if you have a central line, you can add that. So those are the two pressures. So just in terms of summarizing then, RV size, RV shape, RV function, RV pressures, those are the way that we assess the RV. Any questions about these, please come and ask when you're on your rotation, and we'll be happy to explain it to you. Okay, thanks for watching.